Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. Today, we'll be discussing federal tag updates related to opioids and substance use disorder. Everyone has entered this meeting on mute, but we will have a discussion at the end of this webinar. So if you have any questions or comments, please submit them to us using either the chat or the Q&A tool in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our webinars in this series. For next week's webinar, we will continue our discussion of the Phase 3 updates. Next week, we'll be focusing on training requirements and the new TNA guidance updates. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. And now I'd like to introduce our guest today, Pam Metter. Pam is the Director of Regulatory Services with the West Virginia Healthcare Association. So Pam, welcome back. It's good to have you again. And if you're ready, you can go ahead and take it away.
Fantastic. Thank you, Kathy, and thank you, Quality Insights, for allowing me to come and talk to your audience again. Am I unmuted? Can you hear me?
We can hear you, yes.
Fantastic. Thank you very much. Okay, good job. Okay, so we're going to talk about as Kathy says, we're going to be talking about the federal tag updates, and we're going to focus on the opioid and substance use disorder portion of the tags. So I want to first I'm going to go ahead and take my video off since I don't want it to be distracting because but this first slide is talking about Appendix PP. This is where many of the or all of the updates are coming from. We've got a link there, and I'm sure Kathy will be sharing this link. I refer to the Appendix PP as a study guide. Everything within that we're going to be talking about is within this link. All the red data that's written within Appendix PP is the new updates that occurred the October 23rd. That's when they went into effect. So we are only going to be going over the newest updates. I'm not going to be going over all the old information that was already there prior to. We're just going to hit the new updates that you might not be aware of. And there we go. The first one that we are going to start with is F755, which is pharmacy services. Much of the information in this section is talking about fentanyl transdermal patches. They focused on the fentanyl transdermal patches because there was a lot of tags associated with the use and the adverse effects and the side effects and disposal of these fentanyl patches. They also focused on the fentanyl patches because there is a huge potential for abuse, misuse, diversion, and accidental exposure because there is a certain amount of medication left in the patch after removal. So CMS is really focused on how to dispose of properly these patches. The way that they recommend that you dispose of them, of course, is to fold the patch in half with the sticky sides together and then flushing them down the sink. I guess they meant like a hopper or the toilet. And one of the things that you need to realize when you're doing this is whether your local law or your state law restricts the flushing of any pharmaceuticals. Now, fentanyl is not in the category, the fentanyl patches is not in the category federally where EPA bans flushing. So that is the recommended disposal by the EPA. So check with your local and your state law to see if fentanyl flushing is permitted. Another thing that it talks about is when you dispose of these, like I know putting them in a sharps container, for example, they do not consider that adequate disposal, especially if it's in the resident's room, or if it's in a trash can in a common area. So, and I put it in bold there because it does stress specifically common areas. So, you know, putting it in a sharps container in the med room is not a common area. So that could be a potential idea if flushing is not an option. You also have to assure that your staff, and this is directly within the regs, you have to assure that your staff is trained on disposal of fentanyl patches. So whatever your policy states, you're going to have a training for your nurses on proper disposal, and that's going to have to be documented training for all nurses who utilize the fentanyl patches. Remaining on pharmacy, we're going to talk about they've pointed out some labeling and storage information to make sure that all of your drugs and biologicals are labeled and tagged as currently accepted. So the date that it was opened, if it was a multi-use vial, all of those things that we always do, what we're supposed to do with biologicals or storing drugs, whatever, they've actually written out exactly what they're going to be looking for. Now, here's a couple of definitions because we're going to move into F689, which is accidents. And you wonder, you know, you think about opioids and you think about those types of things that we're talking about. These tags are everywhere. Not in pharmacy, you would think opioids and that kind of thing would be under there, but it's also there's quite a bit about it under accidents, F689. And they give you a couple of definitions. The first one being opioid use disorder. And I'm not going to read you the definitions. You guys can read those. And then the other one is medication assisted treatment. So that one I am going to kind of point out, it's not just medications. This is in combination with counseling services or behavioral therapies and a whole patient approach. So if you have residents that have been diagnosed with a substance use disorder, and there's a definition for that later on, I just want you to be aware that their medication assisted treatments is not just medication. There's other things that we're going to have to be sure that is included within their care when we are doing a care plan for these residents. And there's the definition for substance use disorder. It's defined as a recurrent use of alcohol and or drugs that causes clinically and functionally significant impairment, such as blah, blah, blah. So if you are taking residents with substance use disorder, which in long-term care is becoming more and more frequent, residents are getting younger and younger because of these substance use disorders. Medication-related dementias, those types of things, it's becoming very prevalent within our long-term care facilities, and it's a true issue for our staff and for our other residents. We've got to totally divert our focus from geriatric care into behavioral care. We've got to start looking at it that way. Now, talking about residents with substance use disorders, you have to be, the new regulations specifically spell out that facilities should be prepared to address any emergency related to substance use. And we realize what that means. Narcan, the availability of Narcan, the capabilities of our staff to administer Narcan. CPR, making sure our staff are up to date on their CPR as appropriate, making sure that our EMS services are aware that we may have residents that are overdosing or have issues with substance use disorder. And I have found that your emergency medical services, they're a wonderful resource to come in and do the training for you, train them on the Narcan use and how to administer and how to monitor for opioid issues or for overdose issues. And they've put this not once, but twice within the new federal regs. The United States Surgeon General has recommended that naloxone or Narcan be kept on hand when there's a risk for opioid overdose. So be sure that you guys, if you have folks on opioids, doesn't have to be a substance use disorder. It could be, I remember when back in the old days, we would have the medication administration, self-medication administration with morphine, and we would have a Narcan taped right on the top. Couldn't do that now. It's a little glass vial of Narcan. We would tape it right on the top. But now we would have to have the capabilities, but you have to have training associated on how to use it. It has to be safe from other residents, so forth and so on. And then there's a link there for some resources on how you can develop your substance use disorder policies and procedures. Continued under accidents. One of the areas is resident-to-resident altercations. And again, talking about opioids and substance use disorders, we know sometimes agitation, combativeness, aggressiveness, whatever, anxiousness, all of that goes along with substance use disorders. So we have to evaluate staff's competency related to behavioral health care and with dementia care. So we have to make sure that our staff is trained, competent, and can supervise and can approach those who may be agitated, combative, aggressive, whatever. So this is our job to make sure that our staff is competent on any kind of resident-to-resident altercation. And it's under resident-to-resident altercation, but it's also referring to any type of altercation that your resident may have. And this portion is pointing to those with substance use disorders. Resident safety. For the safety for residents with substance use disorder. As you know, those with substance use disorder might want to go out of the facility without letting anybody know in order to obtain their drug of choice, whether it's alcohol, whether it's drugs or whatever. So they have addressed this specifically within the regs. They have, it's not really, I didn't really put it here, but there is a section in there that talks about elopement, what's not elopement, what is leaving against medical advice, and the documentation that has to go along with it. So you need to go into the Appendix PP and read what is considered leaving against medical advice versus elopement. And you have to do a little bit of explaining, a little bit of teaching, and a little bit of documentation to show that even though this person is alert and oriented, they have a substance use disorder, but they left without anybody knowing it. There's some different examples and things that you should be aware of within Appendix PP. You also, as a facility, you have to assess whether or not there is a risk for the resident to be doing this. And you also have a responsibility to ensure the safety of all residents, because, you know, personally, we had a situation at the facility I used to work at. We had a younger fellow that was substance use disorder, and this has been years and years before substance use disorder was a thing. He wouldn't go out and get the drugs, the illegal drugs. He would have friends come and visit him, and they would bring the drugs into the facility. And those are things that we have to be aware of, and we have to make sure that we're assessing and care planning those risks. For the care plan interventions, they specifically give you some things that you have to have within your care plan. We have to give the resident appropriate diversions, which I guess activities or whatever the diversions might be to keep them from wanting to do these types of activities. We want to make sure that the resident knows they're to seek us out and talk to us if they have issues. rather than leaving to seek out substances. And we have to document these conversations. We have to advise the residents of the risk of leaving the facility and that they're in order to, and also the risks of doing an AMA or against medical advice discharge. And then we also have to provide them with referrals and discharge plans as soon as possible. And these aren't things, these aren't suggestions that I'm just putting out there. These are things that are literally within Appendix PP that they have listed. All right, let's move on to F697, which you would think opioid management would be our main focus, and that is under pain management. And a lot of this right here on this page is pretty much standard. We might use opioids to appropriately treat acute and chronic pain. They want, but within the regs, they talk about how prescribing these opioids might be something as a secondary thought, and to consider using alternative pain management approaches, which, you know, our physicians are alternative approaches is not their forte. Their forte is medications. It's our job as clinical persons within long-term care to determine what alternative pain management approaches we should utilize, whether it be, you know, a whirlpool, or whether it be guided imagery, or whatever we decide we're going to actually do, not just write down and say we're doing, but actually doing it. That's our responsibility. It talks about the lowest possible effective dose of opioids should be prescribed for the shortest amount of time possible. That's something that we don't prescribe as long-term care facilities. Our physicians and our nurse practitioners, all those people do, but it is our responsibility as clinical leaders to monitor, to make sure that there is a short time frame, that we have a DC date. It's our job as pharmacies, our pharmacist consultant should be monitoring these things. We should be monitoring for effectiveness. We should be monitoring for adverse events or side effects. Those are our responsibilities. The last bullet point talks about long-acting opioids may provide more consistent pain relief with less breakthrough pain. However, for a resident with dementia, the immediate release forms are generally preferred over the long-acting forms. So they've actually put that within the regs. Okay, use of opioid for pain management's talking now. This one is talking more about the respiratory depression and the use of Narcan and things like that. And it also talks about combining opioids and benzodiazepines should be avoided. If it's clinically indicated, there are things that we need to watch for. If they're 65 and older, that includes falls and hip fractures, cognitive impairment and confusion, daytime fatigue, and delirium. So my suggestion for this is to make sure anybody that's on an opioid, you go through and you check, or you have your pharmacist consultant check to see if there are benzodiazepines as well as opioids. And if there are, then we need to find out if that's the only clinical interventions that can be utilized. And if it is, if the physician said, yep, this is what we have to do, then we have to increase our monitoring for side effects and any type of adverse reactions. These are just some resources that if you're not sure exactly how to handle the benzodiazepine and opioid combination, if you're not sure how to present it to your physician, because this physician has like several residents on this combination, these are some resources that you could utilize in order to do some fact-based exchanges with them. I think, no, that's not a different, that's just more resources. Now, this one, the second bullet point talks about residents with opioid use disorders. You may have to include their medication assisted treatment. And if you'll remember, when we talked about that before, they've actually got it documented under pain management that this includes therapy, this includes behavioral techniques, not just medication. So they've spelled that out once again, not only under accidents, but under pain management. I think that was there we go. Okay. Now our assessments have changed a little bit also for pain management. Included within our pain management assessment is going to be a history of addiction, past or ongoing, and related treatments for their opioid use disorders. So make sure within your nursing assessments, those and your pain assessment, their history of any addiction is listed. And then also if they're on any medication assisted treatment as well, that would be a question. Now they might not know it's listed as medication assisted treatment, but they definitely know if they're in therapy, if they're on anything for any type of history of addiction. And this is both alcohol and drug use. More about monitoring. When you admit folks with substance use disorder, there's some more assessments that you have to include within it. One of them is to evaluation of the time and day patterns to their complaints of pain. They say that if you're considering that this resident is drug seeking, and you want to evaluate their pain patterns, time or day patterns, to see when these requests for pain medicine is occurring. It also is pointing out that this could be due to drug diversion. We had a nurse who was, she would pass meds on one hall, but she would go to the other halls, which the 2 med carts was in the same med room, and open up their med drawer, and she would replace the residents' Percocets with Tylenol 3. And no one would really knew it until, till we found out. And pain control was the thing that showed us that this resident was not getting the pain control that they needed from the Tylenol 3. And then we found out she was supposed to be on Percocet, but they were Tylenol 3s. So anyway, we evaluating for time and day. So if a resident is getting pain medicine routinely all night long, but still complaining of pain during the mornings, then we need to look at maybe some possible drug diversions. The facility, again, opioid overdoses, your facility has to have a written policy based on potential opioid overdoses. What are you going to do? How are you going to do it? Who's responsible for doing it, and the training associated with it. There's another resource, and then there's a tag there, F757, unnecessary medications, that you could be tagged on if the staff is not monitoring for proper adverse effects of the opioid use. Okay, and what are those adverse effects and side effects? They actually pulled from the CDC a number of side effects that opioids can cause even when given as directed. Some of those they've listed through here, including whether or not they become dependent on it, whether if they become tolerant to it with an increased pain levels. Constipation, one of the big things that we always had to do was make sure if a resident was on a pain medicine, they were on some type of stool softener or something that would prevent constipation, because that could be a sentinel event if they got an impaction. So we got to that's another thing to look. If your resident is on some type of opioid or some type of pain medicine that causes constipation, that they're also on something to prevent it. Nausea, vomiting, dry mouth, sleepiness, depression, itching, sweating, etc. So all of those things should be on, and we put them on our MedMar and our nurses documented every time that medicine was administered, whether or not, or whenever they were determining if the pain level went down, whether or not any of the side effects went down. Okay, let's move on to F949, behavioral health. I think everybody knows that's probably on this call realizes that behavioral health in long-term care has become one of the biggest, I don't want to say problems, but one of our biggest challenges, because we're not trained as behavioral health, clinical type behavioral health personnel. So we have to make sure that our staff is competent to the skills necessary for the care specific to those that are diagnosed with a mental condition. And that includes any type of substance use disorder, trauma, any type of history of trauma, post-traumatic stress disorder. Our staff has to be competent on these things. And this is spelled out within the regs. So if these types of care specific items are not within your competencies, they need to be. And it's something that if you're doing a assessment on your staff and you feel like they don't do very well with, say, an aggressive resident, that's something that needs to be included within your competencies. And it doesn't need to be just for that one person. It could be for everybody. You could do training associated with that for everyone. Okay, that was my entire presentation. And I want to I've got the chat here. I'm not sure. Oh, okay. Many of it is. Slides will be available. Yes, I'm going to share. So, Kathy, I'm going to turn it over to you for questions.
Okay. So in a minute, we'll begin the Q&A portion. We haven't gotten any questions so far, but we have time. So if you have any questions, please submit them using either the Q&A or the chat tool. And in recent weeks, we've also allowed people to raise their hands if they would like to voice their question. We can allow you to talk if that's an easier option. So any of those options. And it looks like we've got our first question. It says, for behavioral health, do you have to have specialized SW or therapist engage routinely?
I don't think it doesn't specifically say thou shalt have your social worker do this or that. And again, social work use depends on the size of your facility based on federal regs, but they are trained in people skills. So social work and therapy would definitely be a huge benefit to having, if you have residents with substance use disorders that have issues, and not just substance use disorder, your dementia patients, you've got a lot of tools in your tool belt with social workers, with Alzheimer's Association, and they can help you solve a lot of problems if you have a good relationship with your local Alzheimer's Association. I utilize them all the time. If you've got a situation and even if it's substance use disorder and you've got somebody that's having some behavior issues, call and see what kind of suggestions they have to help with that. But yeah, your social worker is a great tool, but it does not say thou shalt utilize the social worker within this situation. But if your facility is large enough and you have a specialized social worker, they'd be a great team member on this.
All right, thank you. We have another question here. Okay. If we don't take residents with SUD or OUD, do we still need to follow these regulations?
Yeah, because, well, it depends on the situation. Like a lot of this stuff for accidents, for example, they mention specifically substance use disorder, but it's also for dementia patients. It's also for mental health. If you've got residents with mental disabilities or anything like that, if you've got residents that are, in pain if they've had a fractured hip or something like that, and they're on opioids, they're not really substance use disorder, but they're utilizing the medications that could be substance use disorder related, then yeah, you just need to kind of make sure that your residents that are on these opioid medications are covered under the under the different areas: accidents, behavioral health, pain management, pharmacy, all of that.
Okay, so that's all the questions so far. So I think I would like to run through some of our closing items, and that gives people another chance to write any follow-up questions that they might have. And as I mentioned in the chat earlier, I will be sending an email to everyone who registered for this webinar later this week, and I will send the recording of this webinar and the slides. And then once you open the slides, you can get to all the links if you wanted to click on any of those resources. So while we're waiting, I'd again like to invite everyone to join us for next week's webinar, which will also be at 2 p.m. Wednesday. And we'll be continuing this discussion of the recent phase 3 updates. And next week, we'll be focusing on training requirements and the new TNA guidance updates. And in addition to our webinars, we host office hours twice a week with live chat rooms where you can stop by and someone on our team will be there to answer questions or comments that you might have. So if you have questions or comments from today or on other topics, you can drop in during those hours and someone will be there to answer your questions. So if you're interested in attending those office hours, those are every Tuesday at 8 a.m. and every Thursday at 2 p.m. And you can find the links to all of our webinars and our office hours in the newsletter we send out each Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me and I will get you on that list. And my email is ccaudill@qualityinsights.org. And I will drop my email in the chat shortly so you can copy that down. And looks like we don't have any more questions. I think we can take another minute just in case anyone has anything. Let's see, someone asked, will this recording be available? Yes, I'll be emailing it to everyone who has registered for this webinar. So I'll be sending it to the email that you used to sign up for this webinar. And then I also will be posting it to our YouTube channel. Then we share the link from our YouTube channel on our website. So you can check back to qualityinsights.org/QIN on our multimedia page. That's where we put the videos. And we also upload it as a podcast. So if you like to listen to these instead of watching a video, that's another way to enjoy the episode. Let's see. Someone said great information. Thank you.
And I've dropped my email in the chat as well if anybody ever needs to get in touch with me as well. So
yeah, thanks. So that's pmedor@wvhca.org. PMEADOR.
Yep.
Voicing that for the podcast. All right, I think that's just about it. So yes, if you need Pam's
Someone
email.
did ask a question,
Oh.
Kathy. Do you have any suggestions on how to accomplish the competencies that are referred to in the regs?
I knew that one slipped past me.
That's okay. Some folks like to do the competency fairs. And to utilize, and I think Alzheimer's Association has a lot of like example type competencies that you could include within your trainings in order to help folks utilize those. The competencies to me are always difficult, but and there's so many things that we could include on it. I'm not sure if there's anything out there specifically that says in order to check this competency, do that. That'd be a good thing for us to research and see if we can find any behavioral health competencies that are readily done. So why reinvent the wheel if we can come up with some resources that tell us how we can develop those competencies? So that's a really good question.
Someone said Q&A. We use quizzes based on the content trained.
There you go. That's a good idea.
I want to make sure that we're all done here and that everybody had a chance to ask their questions. Again, I'll be sending this email out with this information, and I will include Pam's email in that too, if you want to be able to reach out to her instead of hastily trying to copy and paste this entire thread here. Okay, I think we can wrap up. So again, if you need to contact me, you can reach me at ccaudell@qualityandsites.org. If you want to contact Pam Metter, you can reach her at pmeador@wvhca.org. And if you would like to see any of our other webinars, you can find them at qualityinsights.org/QIN/multimedia. I'd like to thank all of you for joining us again today, and we hope to see you back next week. And Pam, it's been great having you back here. We hope to see you again soon.
Thank you guys so much. Take care.
Bye.